Thank you for joining us today. If you're listening to the live webinar on August 17, 2017, and would like to earn ASHA CEUs for this course, be sure to attend the entire 1-hour session. The handout and all the forms you need to complete CE credit will be emailed to you after the webinar. Mail the ASHA participant form and the evaluation form to the address shown at the bottom of the slide. The forms have to be postmarked no later than August 25, 2017. If there's more than one person at your location, be sure and download the attendance sheet and have each person requesting CEUs sign the sheet and complete the ASHA participant form and the evaluation form. No CEUs are offered for the recording of this session that's available later on the website. And with that taken care of, we'll turn it over to Dr. Adam Scheller at this time. You ready, Adam?
All right. Thank you very much. Hi, everybody. My name is Adam Scheller. We're going to be talking about CELF-5, PLS-5, and Shaywitz today. We're going to talk about screening in general. So you're all with me for the next hour. Hopefully you're comfortable and have a nice little handy snack next to you. So in addition to the stupendous and serene Sherry that you heard at the beginning, she will be helping with the chat box, any questions we have in there with regard to just practical issues. We also have the noble and nice Nancy, who is, you just heard her voice. She will be on the line as well to answer any technical test questions that I can't get to. And again, I am the animated and amiable Adam. Yes, I have been reading my thesaurus, so hopefully that all came through pretty well for everybody. So let's stop the joking, I guess, and get into the content. But I am an employee of Pearson, pretty straightforward. I am employed by Pearson. We are the publisher of all of the assessments I'll be talking about today. So I just want to make sure that you all know that. I'm not going to present other screeners, but I will discuss those 3 that are listed. In terms of the agenda, we have these 6 points to cover. I just want to make sure that these are all the points that we have listed in the ASHA CE docs. We have to make sure we get to all of these today, so I'm going to kind of push through some of them a little bit quicker than others. Just a quick note to everybody that please just remember to follow professional guidelines for test security. A lot of the stuff that we're going to be talking about today, and I will show you some proprietary information, as well as in the handouts, although the handouts don't include all of that data. So just a quick reminder for everybody. So in that time frame, in the hour time frame I discussed, we will hit on some of the benefits and limitations of screening. So I'm going to talk about screening in general and how it applies to speech and language specifically. I know that we're going to be talking about 2 different types of tests today. We're going to talk about language screeners and a dyslexia screener, but you know, the ideas and the benefits and limitations are pretty much the same. So I want to be able to review those with you. And then I'm going to describe interpretation of, describe the PLS-5 and Shaywitz and talk a little bit about interpretation for those. Again, if you have any questions, please feel free to put them in the chat box on the bottom left-hand side of your screen. So let's first start with points to consider for screening. So you have to ask yourself why you're using a screener. Sometimes it's pretty obvious when we have large numbers of children that have to be evaluated to meet specific criteria when we want to be able to weed out which children need assistance. That's pretty straightforward. There are also situations, and this kind of goes back to the pre-referral discussions that we used to have in the early 2000s, late 90s when RTI wasn't well established in the U.S. But really when referral processes are not clearly established and when that referral process has a poor hit rate, meaning you're not really picking up the kids who need services very well. And that's why screeners can be very beneficial. But the third point there is, I would say, the most important. Intervening has benefits for prognosis. So we know that the earlier that we intervene on difficulties, particularly with regard to speech and language, the earlier we intervene, the better for that child's prognosis. So let's keep that in mind today. The first thing I'm going to talk about is with regard to why we're screening language in the school systems and why we're looking at it earlier and earlier. We all know that language leads to literacy. It's the idea that the oral language components of development occur first or start to develop first, leading into the development of the written language components of learning. And we know that leads into or possibly leads to certain difficulties in the classroom. So I want to make sure that we're all on the same page with that. It's super important that we screen for and look at a child's oral language early enough if we're considering some certain difficulties or we want to intervene. That's pretty straightforward. ASHA in 2001 did come out with a really great list of what developing language competence means, and really describing between the connections between oral and written language. And I have them listed up here because it brings us back to the same place. It makes us remember why understanding that link is so important. And the first point there is that, as I just discussed, oral language does provide you with the foundation for the development of reading and writing. And that word foundation, I think, is super important. I believe that word foundation is really the key that we're thinking about here, that if we're talking about reading and writing difficulties, we have to take into account a child's oral language development, right? Pretty straightforward. The second one is that the relationship between oral language and literacy is reciprocal, and the interconnections originate early in childhood. And that reciprocal nature is also very, very important. We know that some children come to school having heard a significantly different amount of vocabulary than other children. Hart and Risley, going back to the 70s, talk about the differences between SES and professional status of parents, and leading to differences in how much vocabulary a child hears. And they very clearly state that the research, even into the 2000s, they've continued this research, saying that children of families with lower SES tend to hear a significantly lower amount of vocabulary than do children in families with professional parents or with professional degrees. So the difference is staggering, somewhere between 500,000 to 4 million for children of professional parents, professional careers. So we also know that difference between language or exposure to vocabulary leads to then the differences in how a child produces vocabulary, how much vocabulary the child actually produces. So we know that then the children with speech and language difficulties or lower vocabulary levels can be at increased risk for difficulties with early and conventional literacy development. And the final point there is that intervening for oral language can positively influence literacy development and vice versa. And that's also sort of second to that other point that I talked about with the reciprocal nature. So we know that when we intervene early enough, and this really hits that point that I talked about earlier on a few earlier slides, we can influence their learning in written language. It's super important to think about. Now let's talk about why. Again, this is just sort of a general slide about what we just talked about. But in terms of intervening early enough, it allows us to close that language gap quicker and quicker. Let's talk about some different points regarding screeners that we have to be aware of. We have to know why we're choosing a screener. We have to know what it's for. We have to know what questions we're trying to answer, because it's not right for every kid it's not the correct assessment choice for every child. So we need to figure out why we're choosing specific screeners. The limitations are where we need to start. These may seem pretty straightforward and apparent, but they're not always. The important thing to remember, number one there, is that screeners should not be used to provide a diagnosis. They are not developed for diagnostic purposes. They are developed to indicate to us which behaviors or which skills can potentially predict difficulties later on, or risk or at-risk status. So that's super important for us to remember. They are not comprehensive. They may take a snippet of what we're looking for and say, hey, these items that we're assessing in this screener, they're the best at differentiating between a child that's at risk or not at risk. So that's super important to remember. We can't drive the diagnostic formulation with a screener. However, if you use diagnostic data, or if you use screener data to drive diagnosis, that's okay as long as we take that sort of in context. So if I say, hey, I have a screener, this child came out as at risk on the screener, and furthermore, I have a significant amount of observational and archival data, and also teacher data that shows that this child is at risk or has these specific characteristics, that can start to lead into the diagnostic process. But you shouldn't use this just for diagnosis. They are not designed to identify a degree of impairment. So it doesn't, when we're looking at the data coming from a screener, we can't say oh, this child is more impaired than another. It doesn't allow us to do that. And it should not be used to identify a pattern of strengths and weaknesses. That's pretty apparent as well. The question that you need to think about is, what are you trying to answer? So the question is, what is your question? Does this level of data suffice coming from a screener for what you need to answer? And that's really what we have to fall back on. Are we getting enough data from a screener for the specific question we're trying to answer? And I want you to start to think about what those questions might be, because oftentimes we may immediately go to a diagnostic question. Well, then this is not the right way for us to go. But if we are trying to sift out or to identify the children who are at risk, the children who we want to be able to put into or expose to higher levels or more intensive levels of intervention or exposure to vocabulary or exposure to language, we have to be able to define or decide what that question is going to be. Really, the idea is, in order for us to choose a screener and what type of screener we should be using for a case, we have to be able to balance practical versus outcome. And what I mean by that is, what are the resources that we have available? How much resources or how many resources can we put into the screening process versus how many children or what level of identification needs to happen? If we think about that first point in terms of practical, again, it's time and resources. Because if we take a test that is going to require a higher level examiner, somebody who needs a specialized degree, somebody who needs a specialized level of interpretation or interpretive capability, it's going to take more time to get that done. The resources, how much can we actually sit down face-to-face with a child? That's another consideration you have to make. Are we going to implement something that's going to be observational? Are we going to implement something that's going to be one-on-one assessment? These are all questions that need to be balanced for the practical component. How much time and money will be required for you to catch what you're looking for? So I have the term catch in quotation marks there, because really, if you think about it, the larger the hole, the less time and resources you'll need. So that means less children to catch. The smaller the holes or the more detail-oriented, the more time and resources you're going to need. So you really have to balance that between the two of them. A lot of times at the universal screening level, we tend to be satisfied by something that has larger holes. That doesn't always need to be the case. So I will show you some examples through today's talk that doesn't have to happen, but you have to balance between the two of these. And with regard to outcomes, what are the implications for you missing a child in the screening process? So we know that there are going to be two areas impacted. One is the impact on the student, and the other is the impact on your organization. You have to balance that as well. If we miss a child with a language delay or possible language weaknesses in areas that we could potentially be intervening for, what's the impact going to be on that student long term? Well, I will tell you that, as we talked about earlier in this presentation, that impact could potentially be pretty big. If we're not building the foundational blocks of written language early, and that is through the development of oral language, then we know that their reading can suffer. Reading and writing will and can suffer later on. The impact on your organization is pretty significant as well in terms of the time and resources that you're taking in special education. How much time does your district have to spend in special education to try to remediate difficulties later on? Is it not only time and resources, but then is it an impact on the overall perception of your school district, your building? Are you doing the job correctly? Is the public, your consumer, viewing you positively? You have to balance that idea between false positives and false negatives. Are we identifying too many kids that do not necessarily have a speech and language difficulty, or are we forgetting or we're missing the kids that need it? That's the false negative. A lot of times, we hear in research and literature the idea that identifying too many false positives can be negative. And that's absolutely true. If we're identifying too many kids as at risk, there are a lot of difficulties with that, both organizationally and impacts on the student. However, there are certain components that it really depends on how your school district addresses those identifications. So if you are identifying a student with oral language weaknesses early on, and what that means is that they're getting more services or they're getting more exposure or more enrichment, the impact is going to be minimal. However, if you're identifying a child with a disorder early and they don't have a disorder, what are the potential impacts there? Well, you may be pulling them out of class. They may be losing time in instruction. They may feel some type of alienation or poor self-esteem. There are lots of compounding or impacting issues that could occur there. So you have to balance that as well. It's really important that we consider that. And finally, in terms of screener usage and choices, you have to fit one that's going to fit your system, or you have to choose one that's going to fit your system. I apologize. So that's really the main point here that you have to come back to. What are you currently using? How many resources do you have? How much time and money can you devote? How specific or how large do those holes in the net need to be? How specific does that screener need to be? And at what level do you wish to implement that screener? So there are different levels based on what you're looking for. If I'm going to go to dyslexia screening or reading screening for reading weaknesses, as I'll talk about later on today, whether or not you apply it for everyone or just kids who are identified with potential weaknesses at the Tier 2 level, really that's another decision you have to make. Again, what question are you trying to answer? What level of data will suffice? I put that in there twice because it's so important. That's really the foundation of your choice. So let's do this. Let's get into the PLS-5 screening tests first so I can talk to you about what they are and what we're actually looking for. So we are going to talk about both the Spanish and English versions. This first slide is going to be mostly, these first couple of slides are going to be mostly about the English version, and then I'll get into what the difference is between English and Spanish. So the PLS-5 screening test its purpose is to identify children who may need an in-depth assessment of their speech and language abilities. It can also be used to monitor children who have been dismissed from therapy. So if you get to that point where a child is doing well enough and they're dismissed from therapy, you can use this test, which is going to be quick, to be able to monitor their progress over time and whether or not they continue to need it. With regard to ages and administration time, we can use this for birth through 7 years, 11 months. There are going to be 8 separate record forms for each year of the age. We have ages 0 through 2 years, 11 months, and 7 0 through 7 years, 11 months. They're going to be new categories for this 5th edition. So if you're familiar with PLS-4 in the screening, these 2 new areas do extend down to birth and up to 7 years, 11 months. And again, administration time here is quick, 5 minutes to 10 minutes, but it is an individual administration. We're not looking at group administration here. So that's important to remember. Remember, go back to that resources question I asked you earlier. Here are some important points. We do have English and Spanish editions that I'll get into. We're looking at criterion-based scores here for performance. Now that's, again, going to be slightly different from what we're used to with diagnostic assessments. We're not going to specifically be looking at a child's performance and comparing it to a peer group or a norm group and saying this child's performance, i.e. their raw score, corresponds to a typical performance for a child at the 70th percentile or at the 10th percentile. What we're doing here is with criterion scores, we're able to look at past criteria, or we're able to apply past criteria for each of the domains that are assessed so that we can say this child passes the screener or does not pass the screener. And that really allows us very quickly to say these areas are at risk or these areas are not at risk. So for children in the U.S., the standardization norms or the comparison came from kids in the U.S. for the English edition, and also kids from the U.S. and Puerto Rico for the Spanish edition. Now, if you use the PLS-5, the comprehensive version for diagnostic testing, the easy thing about using something like the PLS-5 screener is that you can just transfer the scores to the protocol and you don't need to re-administer the test items. So that does save you time in the long run. So you have to balance the two, what you're going to be using. Again, you're going to be able to take that and then just put it in, basically put it in the scoring for the PLS-5 comprehensive. The last point that I have here is that the language items are going to be the most discriminating items from the PLS-5 and Spanish, the PLS-5 Spanish. So again, this goes back to the point I made earlier, is what's the point of a screener? The screener takes specific items and looks at whether or not they discriminate well. They discriminate well between a quote-unquote normal or non-atypical group and the atypical group or the at-risk group. So it's important that you know that. These are not going to be comprehensive items. They're just going to be selected to say, hey, these are the best at differentiating between the two groups. So if we're looking at the infants and toddlers, because all the way down to 0 and all the way up to 7 years, 11 months, we're going to be looking at very different types of speech and language. So in infants and toddlers, again, it's pretty straightforward. Again, we're going to be looking at emerging communication. We're not going to be looking at specific communication, but we are going to be looking at emerging skills. So in infants, auditory attention and vocalizations. For toddlers, we're going to be looking at language comprehension and expression. In infants only, we will also be looking at feeding. So we're going to be looking at a description of atypical behaviors here. And the same is true for social and interpersonal skills. We are going to be also looking at atypical behaviors. So it's interesting because I talked about a test earlier this week, and in that test, what I described was the presence of atypical versus the absence of typical. So for a test like the PLS-5 Spanish, we are looking at the presence of atypical behaviors. Now, again, those behaviors may not be diagnostic. They may not be the only information that you need to drive your diagnosis, but they will help you differentiate. They will be good predictors of possible weaknesses or possible issues going into the future. Here's an example of what the record form looks like. Now, you don't have this in your handout, but this is an example. I wanted to show you what it looks like so that you get a sense of what you would be testing with something like this. So again, this one is for birth through age 0 years, 11 months. And you can see that this is the language section for birth through 0 years, 5 months. And you can see each of the questions, there are 5 of them. You would rate the child on a score of 1 or 0. So if we look at item number 1, glances momentarily at a person who is talking to him or her. A score of 1 would be the child glances at the speaker for 1 second. And a score of 0 would be the child does not glance at the speaker or glances for less than 1 second. So based on your observations, based on your elicitation of this behavior, you would score the child as either 1 or 0. And it would be the same for all 5 of these questions. Additionally, what's really easy here on a test like this, and I really like these record forms for this very reason, is that the criteria for the total of pass and fail is listed here at the bottom. So you'd add together, you'd sum together items 1 through 5, and if the child got 4 or more, they would pass this domain in the screener. If they got 3 or less, that would be, we would consider them as at risk in language. The other thing that's great about this is it does show down here in clinician's note, it says that the corresponding PLS-5 numbers are provided for each of the PLS-5 screening items, test items in the language section. So what you can see is on the right-hand side, it tells you what items they are in PLS-5 comprehensive. So you can see that item 2 here corresponds to AC3. Item 4 corresponds to AC8, etc. So you have, or is that a 6? It's a little small on my screen. So you have the ability to go back and just show where the screeners fit into then the comprehensive assessment later on. Here's another example with feeding and interpersonal. And again, a child would pass these if none of the behaviors are noted. So again, that's listed here at the bottom, the pass criteria. You can see that at the bottom. It's pretty straightforward. So check all that apply under feeding. Does the child demonstrate any of the following behaviors? Difficulty latching on to nipple from a bottle and or breast, has difficulty sucking from a bottle and or breast, etc. So you get to go through all of these questions, and if a child does demonstrate these, that would be then what? That would be the presence of atypical. Remember how I differentiated between those earlier on. So we're looking at atypical behaviors here. And if we look down here at the bottom, we can look at the screening summary. So you check the box for each section. If the child does not meet the pass criteria, check obtain additional information. So for our example, if the child, let's say, has frequently coughs, gags, or chokes during feedings, you would know then they did not pass feeding, and you would mark the box obtain additional information. Otherwise, on the first one, we talked about the child passed language. Social interpersonal, we didn't go over yet. But you see then the social interpersonal has behaviors that are atypical as well. So that's really the ease of it. It's a pretty straightforward and easy test to give, and then you're able to kind of transfer that over if necessary. In terms of what we're looking at for children 3-0 through 7-11, we are going to be screening in 6 areas. So we have language, articulation, connected speech, social and interpersonal communication. So from 3 to 7, that describes typical behaviors. So I want you to be able to differentiate between the two. Again, the younger kids, we're looking at atypical. 3 to 7, we're looking for typical. We are looking at fluency. We have both typical and atypical behaviors, and also voice, atypical and typical. Here's an example of what it would look like on the record form for the older children. So you can see here at the top we have articulation. The child would be articulating those words, so pan and pot, and whether or not they got the item correct or incorrect. And some of these words have we're looking at two different sections or two different letters. So we have dog, we'd be looking at the D and the G sound, and the same is for monkey. Same is true for monkey. If we look at here under connected speech, you would pass if you understand most of what the child says. So, if you're having difficulty understanding the child, you would then mark the corresponding box to why that was the case. But if you can understand most of what they say, they would pass connected speech. Social interpersonal. So remember when I said about typical and atypical, greets you when you say hi, responds to your questions, speaks to adults, asks questions, says bye when you say bye. So that would be 4 or more statements checked would be a pass criteria there. And then we have fluency and voice on the screen as well. So we can see here then at the bottom of the screening summary, we have pass and then obtain additional information sections depending on how they do on each of the screening domains. With regard to the screening test results, again, you can go back to that screening summary I talked about. We have the pass or obtain additional information column for all of these different areas. And really the idea is that if you have children that are checking that have several or a box checked for obtain additional information, in that situation you should be then referring for additional assessment. At minimum, you should also then think about whether or not additional levels of intervention or additional exposure or enrichment can also be applied at that point. Okay, let's think a little bit about the PLS-5 Spanish screener. So for Spanish, the purpose of this version or this edition is to identify monolingual Spanish or bilingual Spanish English-speaking children who may need an in-depth assessment of their speech and language abilities. So again, we're looking for either monolingual or bilingual Spanish English. You can also, again, use this the same way you use the English version, which is to monitor children who have been dismissed from therapy. In terms of the evaluators, or who should be evaluating using this version, the evaluators should have fluent or near fluent Spanish for administration to monolingual Spanish speakers. If they are testing bilingual Spanish English speakers, they should be bilingual, or they can use a trained and qualified interpreter. So that's really some guidelines for you when you're choosing this test to give it. And if you have monolingual Spanish, you should also be fluent or at least using an interpreter. Let's look at some of the administration points just so you understand the difference here. Monolingual Spanish-speaking children are administered only items in Spanish. So we do not administer any of the items in English. For bilingual children, we will administer the language items in Spanish first. And if they don't meet the pass criteria, then we administer the box that's labeled administer in English. So that's an important one to remember. We have the ability to start testing them in Spanish, and if they don't pass it, then there's a separate section that says this is what you should administer in English. So you then go back and give that to them. And if they pass it in English, then they get credit. So they can pass, bilingual children can pass in either Spanish or in English. And the last point here is you should score items by considering both English and Spanish responses. That's super important. So if they're giving you either English or Spanish, you would give them credit. All right, let's talk about the CELF-5 screening test. Excuse me. So what is it? Well, this is a test that's used, again, to determine if a student needs further testing to identify a language disorder. Now, this is a big difference between the PLS-5 screener and the CELF-5 screener, but it is appropriate for students that are 5-0 through 21 years, 11 months. Now, this is the only test that is standardized for older school-aged children. So if you need a screening measure for older children, the CELF-5 screening test is available for that purpose. So that's a real difference between the others. If you're looking at kids under 5, the PLS-5 screener is appropriate. Kids over 5, you have the choice 5, 0 through 7 years, 11 months, you have the choice between either one. Now, these are important points to remember about the screener. So this is going to take approximately 15 minutes. Again, a little bit longer than the PLS-5 version. And again, if you go back to your choices, why are you choosing specific screeners? You have to balance between the two. The screening items are, again, going to be a subset of the diagnostic SELF questions. So it is important that you remember it's made and balanced basically in the same way. So you can transfer many of the screening test responses to the SELF-5 protocol, and you don't need to re-administer those test items. So it is made, it was developed in a very similar fashion. It does include a pragmatic screening in addition to the items for morphology, syntax, and semantic skills. Again, that's going to be age appropriate, but we do have the ability to screen for pragmatics using this test. It does provide the only screening measure. It's the only screening measure with research-based criterion scores, again, for older age students, and we have those cut scores presented by age. So it's really easy for you to interpret those and say whether or not a child passes or needs additional information. And the standardization sample was very large, 2,300 students throughout the U.S. There was a rigorous analysis of bias that always happens with our assessments, and the scoring rules are going to be sensitive to many dialects in the U.S. and diverse cultures. So if you're familiar with the SELF-5, you know that dialectical variations, we are able to score those on the SELF-5. The same is true for the screening test. So if you have children that are giving words or expressing themselves in different ways based on their dialect, you can give them credit also on the screening measure. So these are referral questions that can be answered using a SELF-5 screening test. Again, go back to remember what a screener can do and can't do, the limitations and the benefits that I talked about earlier on. So what can we answer with this test? Well, we can say whether or not the student's language abilities appear adequate for his or her age. We can also say, should the student be referred for a comprehensive language assessment? Again, remember what we're looking for here. Does the child seem at risk? And do we need more information to drive that diagnostic assessment or the diagnostic formulation? Now, these are going to be questions that would not be appropriate for the SELF-5. So you don't want to ask yourself, does the student have a language disorder? You're not going to be able to answer that. What type of language disorder does the student have? It also does not provide you with that information. It does not tell you, or should not be used to answer, whether or not the student has specific strengths and weaknesses in language and speech. And the other one would be about the student's language deficits and how they affect academic performance. Now, you can start to make hypotheses. So you get, let's say that you're getting a child who has a specific pattern of failures or needs additional information on the screening test, and also they're having weaknesses in certain areas in the classroom. You can start to make those hypotheses to think about how their language might impact their academic performance. But be very careful not to say that a specific area like morphology or syntax is affecting. Make sure you couch that language and don't say is affecting their academic performance until you give a more detailed, in-depth, comprehensive assessment. Because again, remember, these tests are not designed to give you that information. Seasoned clinicians will be able to see patterns that then lead to certain hypotheses and further assessments, but the test doesn't give you that data. So just be very careful not to make those leaps unless you have the data with other sources. So again, these questions here that I have listed, really they should be answered through more in-depth language assessments. Super important you go more in-depth if you have to answer one of these. So for children who are 5 through 8 years, 11 months, we have items 1 through 26 administered to them. We do have items that have are included from word structure, word classes, following directions, and recalling sentences. And if we go for 9, 0 through 21 years, 11 months, so all the oldest of children, 15 through 45 are administered, and we are looking at items from following directions, recalling sentences, sentence assembly, semantic relationships, and word classes. All right, I'm going to take a break here, just not a break, but I'm going to pause and see whether or not I have any questions that came through about the first couple of sections that I discussed. So see here, Nancy. Oh, Nancy's been very busy answering questions. So I don't know if anybody had any questions that came through that I did not answer.
No, if you don't mind, Adam, there's just one more. No one asked the question during your presentation, but we've had questions come in. People want to know if they can use the PLS Spanish for their English-speaking students since it has an English section. And the answer to that is no, it's not normed on typically developing English-speaking students, and the item set for Spanish screening is slightly different than the English. So the language targets aren't all acquired at the same ages necessarily, and the sub-items aren't necessarily the same. So that was the only thing I was surprised not to see in the question, so I thought I'd throw that in.
Absolutely, that's perfect, because it goes off to the point that I discussed earlier, which is that it's meant for monolingual Spanish speakers or Spanish dominant and bilingual Spanish dominant students. So absolutely, thank you for that, Nancy. I did have another question that came through just asking about speech and language screening results showing a child's skills that some folks are talking about them being in the average range, if children are coming through okay. Absolutely, you know, whether or not you're saying that they're average or not average, I would stay away from that type of terminology. That question came from Nancy, from a Nancy T. I would stay away from that terminology because, again, we're not looking at differentiating between levels of severity or levels of skill. So it's important that folks know when you're delivering the results from a screener that they know that the child passed the screener. So it's likely that they don't need additional data to look at their speech and language skills, or that we do need more information. They're at risk. So it's important that it's important that we communicate to others that the results don't mean average. We can't apply that terminology to the results of the screener. So a very good question coming through. All right. I did have a question from Rebecca. Nancy, if you don't mind repeating your question and answer, because it sounds like folks wanted to hear that one more time about the Spanish, giving the PLS-5.
So the PLS-5 English edition is for English-speaking children. It's normed on typically developing children whose primary language is English. The PLS-5 Spanish screening is based on data obtained from typically developing Spanish-speaking children. So the demographic characteristics of the sample match a Hispanic population. The items are based on Spanish development. The sub-items sometimes within, both tests might have the same item that looks at naming objects correctly, but the subset of items of objects are slightly different on the Spanish versions and English versions. So you're able to use the Spanish version with a child who speaks only Spanish or a child who speaks Spanish and English, and speaking Spanish is their primary language. But you cannot use the Spanish screening. You can't use the English items on the Spanish screening to test monolingual English-speaking children. And that's the same for the diagnostic test as well. The PLS Spanish, it's a dual language assessment, but it's not developed for a monolingual English speaker. So I hope that was a little...
No, thank you, Nancy. Yes, thank you for that. Thanks for the explanation. Absolutely. Thank you for doing that, Nancy. And Nancy, by the way, for any of you who do not know Nancy, Nancy is a speech-language pathologist. So you are getting great information from her, as well as being the product manager for some of these assessments we're talking about today. So thank you, Nancy. Another question that came through. So the PLS-5 English, coming from Audrey, is asking, so the PLS-5 English can be used on English-dominant children of Hispanic descent, correct? Yes. The answer to that, Audrey, is yes. You would use the PLS-5 English on English-dominant children, even if they are of Hispanic descent. All right. So let's move on. Let's hit on a different type of screener. So we hit on the language screeners earlier, the tests in the PLS-5 and the CELF-5. Now let's go on to the Shaywitz DyslexiaScreen. So now we're going to switch gears a little bit here, and we're going to move developmentally to written language. And as I talked about earlier, how important it is for us to think about the linkage between language and oral and written language, the idea for schools, legislation is changing throughout the country, and our ability to, or our call to identify and support children with reading disabilities and possibly dyslexia really has increased nationally. So let's talk about this Shaywitz DyslexiaScreen and what it is, and we'll get into this in a little bit more detail. So what is it? It's a brief teacher survey for identifying students at risk for dyslexia. So when I say that, it is 5 or less minutes. It is a screening test that's based on observations. So what we ask is that a teacher or somebody who's most familiar with the student rate the child after about 6 to 8 months of knowing them. So it would be appropriate at about maybe about the winter to fall range if it's a new student coming in. But by that time, a teacher will understand what's being asked of them. So based on what they see happening, they take a quick questionnaire and they fill it out to determine at risk or not at risk. It's going to be intended for use with students who experience academic difficulties, but can also be used to screen everybody. So it's either universal or Tier 2, as I talked a little bit about earlier. It can be applied at either tier. It's only about 5 minutes. It's most of the time going to be less. It's an online form that's not scored, that you don't score. It's automatically scored. It's digital. It's very easy to give. So if we think about the resources necessary to give this, if I think about the time and resources necessary, if we're moving to testing for written language and screening for dyslexia, looking at behavior, this can be done very quickly, and it can be done by teachers, not necessarily have to be done by somebody with significant level of training like speech-language pathologists or psychologists. Again, the classification data, accuracy data indicate moderately high sensitivity and specificity. And if we look at the clinical data that differentiates, the effect size of the Shaywitz screeners is very high. So the ability for it to differentiate between students who are at risk and not at risk is very well established. So what does the SDS measure? It has an emphasis on phonological, linguistic, and academic performance. So there are going to be questions on each of those categories. And again, the ratings are going to be based on classroom teacher observations and supported by other people on the team. So in this situation, what's important for us to remember is that, yes, we are looking at ratings of classroom teachers, but when we bring this data to a team and for somebody to analyze this information, speech-language pathologists play a very critical role. So it's important for you to know that your role in this is most likely going to be about interpretation and understanding the findings of a test like this, because we are going to be based on the classroom teacher ratings. There are going to be 2 forms. So there's Form 1, which is for 5-0 through 6-11, and that's kindergarten, and Form 2, which is 6-0 through 7-11, and that's grade 1. There are further grades in development, but for right now, this is what we have available. I believe grade 2 is slated to come out in the next few months. I don't have the date on that, but we are further developing other grade levels as well. Oh, I did want to mention, I see Tina is also, Tina, I apologize, I didn't see that you were in the chat box. But Tina Eichstadt is also in the chat box. She's also here with me. Tina is also a speech-language pathologist, and she is the product manager for the Shaywitz DyslexiaScreen. So if you see her answers coming through the chat box, folks, as well as with Nancy, she's Nancy's counterpart, she will be answering questions about the Shaywitz. So all materials that you need to administer this test are going to be available in one location on Q Global. So they are going to be digital. They're going to be digitally administered and scored, and also the reports come out that way too. There are 2 report options for this test. So there's an individual report, and that includes the student's demographic information, their risk level, and there's an interpretive statement as well. And there's also a group report that looks at risk levels listed by examinee level. So really what you're able to do is apply a test like this or assist your school in applying a test like this at more of a universal level or a more detailed level like Tier 2, because it's giving you simple classification of at risk for dyslexia or not at risk for dyslexia. Now remember, go back and remember that we are not using this for diagnostic purposes. This test was not developed that way. What it's doing is it's telling us These are behaviors, these are observations that the teacher is making that potentially indicate problems further down the road. So it's not telling us this child has dyslexia, it's saying they demonstrate certain patterns that make us concerned about their risk level. So we are able to differentiate between risk and not risk. Here's an example of what it looks like. So this is not an example of the screenshot, but what this is it's a quick guide for teachers. One of the roles that I find speech language pathologists to be critical with is so that to help teachers understand how they're rating. The rating system is fairly straightforward. But if we're asking about about how well a child expresses their ideas or tells a logical story, etc., it is important for us to help teachers understand how they're going to be rating it. Now, this quick guide is available from us because it helps. It describes out the behavior that we're looking for. It describes how it would be correct or incorrect, and it tells teachers how to rate each one of these items. That's why I said that it can be up to 5 minutes, but likely as a teacher learns this and as we instruct others about how they should be providing ratings, the time limit goes down very low. So it could be up to 2 minutes. It could be 3 minutes for some children. So it could be very quick as well. So let me just go back here. I should have just talked about this first. But like question number 1 is tell a story in a logical sequence. So what we're looking for is sequencing events correctly when telling a story. We're giving an example of what a correct sequence is. We're also giving an example of what an incorrect sequence is. Number 2 here is expresses ideas in jumbled or incomplete sentences. The behavior is speaking in fragmented, incomplete sentences and or sentences with syntax errors. So do you see all this information, this terminology? These are areas where we can really make a lot of strides or be very beneficial in helping others understand how to rate. If we look at an example of the individual report, this is how straightforward it can be. It gives us the raw score for a child, it gives us what the cut score is, and it gives us the classification. So you can see that this child had a raw score of 8. The cut score is 3. That means they're at risk for dyslexia. And it gives you an example, if we break it down, as to why that happened. So if we look at the explanation of results, it tells us that the risk of 8 out of 10 items, there were 5 items pertaining to language concerns and 3 items pertaining to academic concerns. So it does break that down for you, and it really is helpful to indicate where those areas are occurring more often. So now let's go back a second to even thinking about the previous screeners that I talked about, PLS and CELF-5 screeners, and then the Shaywitz DyslexiaScreen. I want you to start thinking about whether or not there is some potential overlap or whether or not there's some potential linkages here that can be beneficial to your students. Thinking about those levels of language, whether or not their language is impacting their written language later on, their oral is affecting their written language later on, super important. So you do get some indications of whether or not that's happening in this assessment. And if you really go back and think about implications for performance on screeners, a screener like the Shaywitz is going to be, you want to think about if a test is not significant. If it comes back and says, well, they're not at risk for dyslexia, what does that mean? What happens if the rating comes up as significant? What if it's borderline? What if it's right around the cut score? What do you do at that point? Well, in this situation, always think about whether or not a screening measure, this really goes back to my initial point, does a screening measure give you enough data to answer the question that you're trying to answer? Sometimes, if you're getting conflicting data, like if it's not significant, but yet this child has significant weaknesses and is demonstrating weaknesses here in certain areas, or they're right at the cutoff, or they're right at the borderline, but they do have some weaknesses. What do you do with that situation? In those cases, always think about referral for additional testing, or at minimum, like I talked about, giving more rigorous intervention, because it is important that at that point you're not only thinking about more data do you need to determine diagnosis if necessary, but you're also thinking about that early intervention and trying to get students' skills back up to speed. Okay. The last point there is in terms of monitoring. Always monitor kids that you think are going to have potential weaknesses or potential issues later on. Always have some type of system in place to say, well, this child is having weaknesses now, but they're not to the level where we would necessarily intervene, but they may later on. We know as academics increase or as grades increase, academics get more rigorous. So just in my personal experience, I have an 8-year-old daughter who just started 3rd grade. And it was interesting because she just started 3rd grade last week, and she already talks about how what the difference is and the expectations of her reading from last year to this year. It's amazing. It only happened, in the past week, and it's going to develop more and more later on. But it does change over time. And those weaknesses, if they appear or they occur earlier, they will definitely show up later on. So it's important to monitor and rescreen if necessary. All right, so what I have here is, before we finish, I wanted to make sure I allowed enough time for questions today, because sometimes, if any of you have heard me just talk before, sometimes I'm a little bit long-winded, so I tend to go to the very end. But if we have questions, we can open it up to those now. I don't know, Tina or Nancy, if you've seen any come through that you'd like me to address, or if you'd like to address some.
We're getting a lot of questions, so I see Tina's very active on here. We've been answering kind of as they come in.
Yeah, if I may, Adam, I'll just jump in and make a clarification for a couple of questions, and then to comments that you made earlier. So just to let everybody know, there's been a lot of product level questions and what do you have and what do you not have. And so kindergarten and 1st grade for Shaywitz, the Shaywitz DyslexiaScreen, are out now on our Q Global system. I think it's September 18th, so in just a few weeks, about a month from now, grade 2 will release, and then grade 3 will come out shortly thereafter, hopefully sometime later this year. And we do have adolescent and adult forms in the works, and middle school things we're thinking about as well. So what we have today is KN1, next month will be grade 2, and then grade 3 is, the data are just about in from our national validation study. So that's hopefully a clarification to some of you who have asked.
All right, thank you very much. I did see a question that came through, thanks Tina, about using the Shaywitz as a universal screener. Do you still need to know the student 6 to 8 months? That question came from Michelle. Yes, the suggestion is that yes, you do. I know screening or universal screening measures or processes for schools are different, but a lot of times the process that's best practice is to have some type of benchmarking system where you are starting children early to see where they're at, and then you have a universal screening system in place at about fall time or winter fall time. And yes, in that situation, Shaywitz is absolutely applicable there. We say 6 to 8 months because in that time frame it gives a child, or it gives a parent, I'm sorry, I'm saying all these different words, it gives a teacher enough time to understand a child's abilities and to rate those questions effectively. So can you do it in less than 6 to 8 months? Possibly, but that's not our recommendation, and that's not how it was standardized. So just be very careful about that.
And Adam, this is Tina. I'm just going to jump in. It's actually 6 to 8 weeks in the manual. So I just wanted to make that clarification. It's not months. Yeah, it's just weeks. And so, and the reason for that, of course, and I said this to somebody on the chat as well, but I'll say it for everybody's benefit. If you're a classroom teacher and you have 25 or more students in your class, you need that much time to get used to that student. So for kindergartners, especially given the wide range of pre-K experiences that they have, we really want them to have enough weeks. And it's 6 to 8 weeks is what we recommend in the manual so that they get that classroom time under their belt. Sorry, Adam.
I'm so happy you chimed in. As I was talking, I was thinking 6 to 8 months. Wow, that's a long time. And in my mind, I kept saying 6 to 8 months, and it wasn't correct. I apologize, everybody. I knew it was 6 to 8 weeks, and
you're fine.
I needed
you're fine.
I don't know. This is my 4th or 5th presentation this week, and I get things mixed up sometimes. So I apologize for that. Everybody's fallible. Nobody's perfect. So I apologize. Thank you, Tina, for that. So in that situation, going back to Michelle's question, 6 to 8 weeks. 6 to 8 weeks. So in that situation, yes, it absolutely would fit into most systems for universal screening, even if using a benchmarking system like I talked about in best practice, benchmarking for the first couple of weeks, and then screening at about the 6 to 8 week level. Thank you. All right. Apologize for that. So we have another couple questions. I have a couple more minutes.
There was a question about, maybe part of that discussion is what prompted the question about and time interval for rescreening on the self-screener. I think for both PLS and self-screening, to Tina's point earlier about giving the child time to, or the student time to settle into their classroom, have the classroom teacher get to know them better. And really, I think before rushing into a re-screening is just talking with the teacher about how the student is doing within the classroom setting, how they compare to similar peers, and determine whether or not you want to follow up with some in-classroom interventions or do actually go on to a full assessment. On PLS and SELF, I'm not sure there's tons of value in multiple screenings, at least not within a short time interval, without talking to the teacher and observing that child in the classroom and seeing how they're doing relative to the other kids in their class. So that's a little bit
I think that's a good point, Nancy. That's a very good point, because when you talk about multiple screenings, you have to question yourself why you're doing that. Because if a child is coming back for multiple screenings, there may be another way to get the data that you need. Screenings might not be the answer to your questions. So that's a really important point. I appreciate that. Thank you. I did have two questions come through that are very similar, which is, what's the next step? What would you recommend for additional testing of those students identified as at risk, or where would you get more data? That's coming from both Cheyenne and Nancy. So some questions after you get, for example, for the Shaywitz, what it's doing again is identifying at risk for dyslexia. What you should then do is start to test specific components of reading. So using tests like the KT, the Kaufman Test of Educational Achievement, 3rd edition, the Wyatt 3, using tests like the Woodcock Reading Mastery Test, 3rd edition, the CTOP. There are lots of different assessments that will address the phonological components of reading. We'll then get into more detail about the cognitive components of reading, so the executive control, the visual processing, all of those areas. You should really start to think about those in more depth. But after a child comes back with at risk for dyslexia on the Shaywitz, my suggestion would be to look at more of an academic measure like the KT3, the Woodcock Reading Mastery Test 3, etc. So those are probably going to be the most common to go toward. Okay, and let's see if any more questions are coming in. Well, we're actually at the end of our hour anyway, folks, so I appreciate all of your interaction. We got some really great questions. I particularly want to thank Tina and Nancy for helping in on the questions, and Sherry for also helping in on the questions that came through. Hopefully you all got some good information today in this past hour. I do have to just review the last slide here, which is just your instructions again for submitting the ASHA CEUs. Just remember that Pearson will submit completed CEs to ASHA if you've attended this entire 60 minutes of our live session, which was today, August 17th, 2017. You should complete the forms that are included in. They were included in the invitations as well as on our website. But there's an attendance sheet if there's more than one person at your site, the participant form, and the evaluation form. I do take that evaluation information very seriously, so I appreciate your feedback. Please mail the forms postmarked no later than August 25th. Remember that date, because if we get them later than that, we will not process them. To Darlene in San Antonio, if you have any questions, you can email her, and we will not submit CE forms if they're mailed later than August 25th, if they're sent via fax or email, if they're submitted for partial credit, that's not available, or if you're viewing this webinar, that is recorded on our website. Again, folks, I hope you've had a great hour spending the past hour with me. If you have any questions in the U.S., please feel free to go to our U.S. website, or our Canadian counterparts, our colleagues up in Canada. Please visit your Canadian website. Otherwise, some questions can be sent to me if necessary. And have a great afternoon.